Hello, and good afternoon. This is Matt Martin. For the next 10 to 12 minutes, I'm going to be talking about acute care surgery practices in a pandemic. I have nothing to disclose other than the fact that I'm certainly not an epidemiologist or virologist, although I pretend I am on Twitter. And my experience comes from both going to New York City in April during the height of their pandemic, as well as our experience here in San Diego, which has been, although lower overall volume, steady and increasing, unfortunately. And if we go back only a few months to March 2020, this was really the scene of everybody trying to get out of the hospital as much as possible, while healthcare workers are obviously on their way in to take care of this increasing pandemic of COVID patients. And this was the scene where I was in New York City, of just nonstop patients arriving, also transfers coming from outside facilities. And all I would say is hopefully nobody else has this experience that they had, especially in the emergency department, which I could only compare to one of the circles of hell of just wall-to-wall patients sick with COVID. And one of the things that happens during a pandemic is essentially everything becomes COVID. It's just patient after patient is COVID, especially in the ICU, or something related to COVID. Or even patients that don't have COVID, it becomes a prime consideration. So the elective surgery patient, how do I need to be screening them for COVID? What if they have symptoms? And that really gets into surgical rationing, which probably many of you have had to deal with in the COVID era now. And this really comes to the questions of, well, what needs to be done? How soon? What are the financial implications of canceling all elective surgeries? And I think that's an important consideration. I think one thing that generally doesn't work is the honor system approach, where each surgeon just decides what's urgent or what's not. There's just too many incentives to game that system. So I recommend establishing a clear framework that should be written. We established a review committee that looked at all case requests and approved or denied those. I think everybody should be pre-screening their patients who are going to surgery, especially elective procedures. And we were fortunate enough to be able to establish two COVID ORs here that were just for COVID positive patients. And I think if you have the resources, that makes a lot of sense. Who does acute care surgery coverage? Again, when your system is overwhelmed and your trauma and acute care surgeons really have to focus on ICU care and even running COVID ICUs, who helps with that? And this is a picture from, again, New York City. This is Dr. Danielle Friedman, who is a bariatric surgery, recent graduate. Although during the pandemic, she was taking care of ICU patients, covering trauma call, covering EGS call. And there, the non-trauma group of surgeons did a great job. And the question is, which specialties are best suited to that? And I think specialties that do a lot of major abdominal surgery, like bariatrics, like surgical oncology or colorectal, those are ideal specialties that are suited to pitch in and help out trauma and emergency general surgery services. Which age groups? Obviously, we want to protect our older surgeons, but in terms of ICU coverage, we found the younger surgeons who are closer to finishing residency were actually very good. They have very good basic critical care skills, whereas surgeons who have been out longer may not be best suited to providing acute ICU coverage. These are all factors that should be considered in your system. These are just pictures. The one on the left is their chair of surgery who came down with COVID. On the right is one of their chief nurses. And it's just important to consider that any plan should factor in probably at least 10 to 20% loss of staff due to COVID or whatever infection you're dealing with in any pandemic. And these could be your key leaders. So that's something to be prepared for. This was a time of changing guidelines and protocols and new ones coming out every day, and a lot of confusion and sometimes a lot lower quality evidence than we're used to operating on. And this can cause a lot of confusion. This was an example of surgical guidelines that came out from the American College of Surgeons. And at first glance, you'll see for appendicitis, they essentially recommended non-operative management of all categories. Symptomatic cholelithiasis, the recommendation was for a percutaneous cholecystostomy tube if they had persistent symptoms, and the same thing for acute cholecystitis. And many of you, like me, may have looked at these and kind of had this response of well, what? But thinking about the implications and impact of those policies, some of it didn't seem to make sense. For example, we know non-op management of appendicitis, you're going to have a 24 to 72 hour hospital stay versus an OR and home. up to a 75% failure rate. And then those patients are going to be back in your ER or your OR or your IR suite, also, again, using PPE. For symptomatic cholelithiasis, I'm not aware of any good data on a percutaneous cholecystomy tube for that. And then for acute cholecystitis, we actually have very good data. Percutaneous cholecystomy has a longer stay, higher complication rate, much higher reintervention rate. And again, that will burn more PPE, use more personnel versus doing an upfront lap choline at home. So these guidelines didn't seem to make sense. And to their great credit, the American College of Surgeons quickly realized that, pulled those back, and within record time assembled a new set of guidelines that make much more sense. As you can see here, and the short of this is, it recommends doing an upfront surgery in almost all of these that will result in a shorter stay, a faster recovery, and getting these patients out of the hospital. And really, it's only if you're overwhelmed and you have no ORs and no PPE that you should be considering those other measures. And so I would just say this supports the treat and street philosophy, or what I call COVID ERAS, which is enhanced release after surgery. Operate on them, get them done safely, get them out of the hospital. And we see a lot of what I call pandemic paranoia, and the GIF, which anyone who's been in the military knows is the good idea fairy. And we really have to be careful about these. And this is a great example. Many of you may have seen, this is an intubation box that companies started producing and many systems bought to try and protect their providers. And what you can see here is, one, now they're having a lot of limited movement. They're bumping against the walls. You can't see as well. That smoke is simulating aerosolized virus. You can see it's coming right out of that commercially made box, so offering very little protection from aerosolization. And what do we know about this? Well, this is just one study. The aerosolized protecting box greatly increased the time to intubation. It greatly decreased first pass success rates. And even more concerning, you can see here, the PPE breaches were none when they didn't use the box, and up to 58% on the most recent generation of that box. So it turns a relatively straightforward procedure into a much more complex, difficult procedure, takes longer, and actually has more chances to break your PPE. So again, I would say really try and resist the good idea fairy in these scenarios, and just do what you know works well, take the appropriate precautions, and if you are introducing something, study it and make sure it works before you introduce it on a widespread basis. Laparoscopy is another great example. We had many pundits or guidelines coming out saying we shouldn't do laparoscopy, it's going to aerosolize. This is a paper in the Journal of Trauma that argued this point of we should be doing less laparoscopy and doing more of these cases open. This is another paper that argued the exact opposite, saying that COVID positivity is not an obstacle. There are SAGES guidelines, which are great. I'd recommend any of you go and read them. They make a lot of sense, and they essentially emphasize a common sense approach to we should be doing laparoscopy, but doing it safely, with concerns for aerosolization, although we have to look at the evidence for that. And this is where it comes down to, it's very important to look at, is this theory or is this known, and how should that translate into policy? So the questions we should be asking are, how high is the risk? Has it ever happened or been reported? And by the way, aerosolized COVID causing an infection from laparoscopy case, never reported yet. And what are the risks of avoiding laparoscopy, which we know are longer stays, more invasive, slower recovery, versus performing laparoscopy? What's our efficacy of pre-procedural testing, or how reliably can we say this patient does not have COVID before going to the OR? And what's the efficacy of our PPE practices? And those are all the things we have to consider when we come up with a policy of something that just says, don't do laparoscopy, which probably, again, in the long run will be harmful. For me, it's a no-brainer. We should be doing laparoscopy with appropriate precautions. Again, this will get the patients recovered faster, minimize complications, and get them out of the hospital where they're at risk. This is a great article I'd recommend to anybody who's discussing this, and they highlight that there's no evidence to restrict minimally invasive surgery. There's plenty of evidence against restricting it in terms of the outcomes. They recommend mandatory screening, and for COVID positive or crash surgery patients, you should wear PPE, you should follow the recs for insufflating, the insufflation gas, and if you can, again, perform these in dedicated COVID ORs. I'm just going to close with a brief mention of resident participation. This was another contentious issue. And initially, a lot of people were proposing residents should be excluded from COVID care, which I call the nanny state. And I think we have to remember these are highly educated and functioning adults. They're trainees, but they're also employees. They're critical team members, and especially, doing surgery, when they recommend, well, just do a hard procedure alone versus with an expert assistant like a resident where you can get it done faster and safer. Again, I think that doesn't really make sense. If you're in an overrun phase of a pandemic like New York City was, you will have no option. You will have no choice. The residents will be a critical part of your response. And if they aren't prepared, then you're not doing the right thing for them. And they should have agency in this decision. And they've made it very clear in multiple surveys that they feel they should be involved intimately in COVID care, that they're a part of the response, and that they don't want to be put on the sidelines. So I say prepare them, protect them, obviously, at all costs. And there should be a no questions asked, no penalty opt-out for ones that have medical issues or other concerns where they don't want to do COVID bedside care. This is less clear for med students and interns where again, I have less of a problem with excluding them from care, at least in that phase of their training. And this is just some of the great residents we worked with in New York City and here at Scripps in San Diego. And again, they are some of the heroes of this response, and the response could not have happened without them. And this is my COVID OR team here at Scripps. This is from a trach we just did a couple days ago. Again, these people are going into the hospital, putting themselves in harm's way every day, and I think we can't forget that. I want to thank you again for the invitation, and I look forward to the rest of the session and discussion afterwards. Thank you.